introduce you to our speakers from Mission Health. Mission has grown to a hospital system serving the 18 westernmost counties of North Carolina. 17 of those 18 counties are largely rural. Clinical services include 5 smaller hospitals, 4 of which are critical access hospitals. Today on the call, we have Dr. Jim Hardy. He is the Medical Director of Ambulatory and Community Behavioral Health and has served since 2013. He is a family physician who has practiced in community health centers from 1981 to 2002 and healthcare for the homeless programs from 2002 to 2013. Amy Roberts is the Executive Director of Virtual Care. She has worked in Mission Virtual Care since its launch in 2010, launching hospital and clinic-based telehealth programs such as telestroke and telepsychiatry in over 20 locations throughout western North Carolina, as well as an online direct-to-customer virtual clinic. Mary Worthy joined Mission Health in 2010, working with crisis behavioral health patients presenting to the emergency department, and is currently the director of the Mission Behavioral Health Access Center. Her focus is to ensure that crisis and substance abuse assessments are provided to patients in the emergency department as well as on medical floors at every hospital in the Mission Health system, either on-site or via telehealth. Darren Boyce is the Director of Ambulatory Behavioral Health. He is a licensed clinical social worker. In 2015, he took the role of Director of Ambulatory Behavioral Health with a focus on facilitating the integration of behavioral health services into the primary care network as part of a shift toward a population health care model. Jonathan Bailey is the Chief Program Development Officer, responsible for leading the development and implementation of new and strategic programs across the system, including oncology, orthopedics, neurosciences, and trauma services. Now I'll turn it over to Mission Health.
Hi everyone, this is Amy Roberts. Thank you, Kim, for that introduction. And we wanted to come and talk with you today about our telebehavioral health program. So the objectives of this webinar, after a brief overview of who we are at Mission Health, we will go into understanding the need, why do telebehavioral health? From there, how it led to our model. A blended model is a solution for that need that we have in our region. We'll talk about some successful implementation practices, the unintended benefits and impacts that we found from our model, and then talk a little bit about our model for integrating behavioral health into primary care. At Mission Health, we're here in Asheville, North Carolina. We're in the western part of the state. We're the Mission Hospital is the tertiary care center for all of western North Carolina. It's an 18-county region. We have 5 rural hospitals and several primary care and specialty practices sprinkled throughout rural mountainous region. So telehealth is a perfect fit for our region. We're a top 15 health system from Truven Health Analytics. We're healthcare's most wired. We employ over 11,000 professionals. We have 7 total hospitals, 400 employed medical providers, and over 1,200 total physicians on our medical staff. Our bigger aim is to get every person to their desired outcome, first without harm, without waste, and always with an exceptional experience for each person, family, and team member. And virtual care fits right within that bigger aim. And it's a way to reach patients where they are at the right time, place, and how they want it. And so virtual care launched back in 2011. Our first program was actually telepsychiatry in one of our rural hospitals, McDowell Hospital. Since then, we've grown. We have expanded our behavioral health program, which we'll go into great detail here on this webinar. We've launched a telestroke program successfully at 9 hospitals throughout our region. We've added clinical programs. We're up to 16 clinical programs. 200 providers every day are providing telehealth services, and we're at 20 locations across the region.
So as we expanded to provide services to our member hospitals, we realized that we didn't have enough volume for psychiatric patients in the member hospitals to staff a social worker there 24/7. So we decided to launch Tele Services to those member hospitals by having our home base here at Mission and working in conjunction with the intake department here at Mission Health. We also expanded by providing 24/7 crisis assessments. So any patient who comes in the door of any one of our hospitals who is suicidal, homicidal, or has symptoms of psychosis, they'll get referred to my department. They will get seen within 2 hours. That is the turnaround time. And we also have expanded it to inpatient. We found that some patients were going inpatient, not staying in the emergency department. So we provide telehealth services to the inpatient units or inpatient medical floors as well. The psychiatrist will round on the patient every day, but we also provide daily therapy, brief therapy in the emergency room as well as on the medical floors, and we do the disposition management. So our model was to take licensed clinicians and use them to perform the tele behavioral health crisis assessments 24/7. When we get the referral, we see the patient within 2 hours of being medically cleared. Sometimes we'll get the referral and the patient will still be intoxicated, so we'll have to wait until that DAL results. But the goal is 2 hours from the consult order. The clinician works hand in hand with the emergency room provider, whether that's a physician or a physician's assistant, to make the initial decision. So the clinician will evaluate the patient and then determine, along with the physician, whether we need inpatient, whether we need outpatient, or there's another path that we need to look at. Also, at the same time, we're looking at whether the patient should be voluntary or involuntary. We really make it a goal here at Mission to keep every patient voluntary. If they come in the door and they are wanting treatment, we do our best to get them that treatment. There are times when somebody is lacking capacity or they're psychotic and they cannot grant consent. We would pursue involuntary if they had that psychiatric component. Also, if they came in and indicated they were going to hurt somebody and then wanted to leave, we would look at involuntary, but we work closely with the ED provider to make that determination. The clinicians have part of their competencies is to understand the laws related to involuntary commitments in North Carolina. We understand that a lot of medical providers, it's very hard for them to stay on top of all of those processes. So while the physician may be the one initiating it, the clinician is the one that's helping navigate all the paperwork and the different magistrates and clerk of courts and processes involved with that. If the patient is recommended for inpatient, then they will be followed by psychiatry. And so the clinician does the initial assessment, and then psychiatry will round on them every day thereafter. In addition, the clinician will also round on them. So every day a patient in the emergency room is being seen by a psychiatrist as well as a clinician, and the clinician is doing brief solution-focused, motivational interviewing type therapy with the patient.
Mary, I'm wondering if with you're doing the Tele Consults with the patient directly in the ED, how do your clinicians typically interact with the attending physician in the ED? How do they get the information back and forth to them?
We have a dedicated phone line to our teleclinician, and they work very closely with the providers. They have that phone number. We also have what's called Jabber, and so the provider and nurses can jabber my clinician if they happen to be in the middle of an assessment and they need something urgently. That instant messaging screen pops up. So it's usually via phone or jabber that the provider is contacting the clinician and getting that information. And we do only accept referrals from the provider. We don't take a referral from a nurse. So it's a physician who has to call us and initiate that. So we stay really in close contact with them throughout the treatment of the patient. One of the other things that the clinician does is they work on finding beds. Due to a shortage of state psychiatric beds, we have a high volume of boarding patients, both at Mission and in our member hospitals, and really it's across the state. Every hospital has that issue right now. So a primary responsibility is to locate an appropriate bed. Again, working with the physician when we find that bed, working with the nurses unit to get that patient transported to the appropriate facility. We have an electronic health record order set that has really been helpful across the board. Once a patient is identified at triage as being behavioral health, it triggers an order set which helps physicians kind of to know which medications are the best to work with individual patients, geriatric patients, perinatal patients. It gives guidelines. It also gives guidelines as to sitter recommendations and does this person need certain precautions placed? Do they need paper scrubs? Are they allowed to be left in their clothes? So a whole order set goes in that gives kind of directives and help and guidance to know how to best care for our vulnerable population.
And people may find it interesting, though, that Mission Health is a Cerner EHR system, and at this point, the main hospital in Asheville and those 5 partner hospitals across the region that we showed on the map are all on the same EHR, and that has made a significant difference in the coordination of care.
Mm-hmm. Absolutely. It really does help to be able to go in and to be able to use the same medical record system for each patient. The other thing that happens, because there is high boarding that occurs, we begin to help treat the patient as soon as they enter the ED. The physician will look at medications. We begin providing that brief therapy. Sometimes the patient will stabilize while in the emergency department, and that's actually quite often. About 40% of our patients right now are stabilizing and they're not going to an inpatient unit. So we are discharging, and one of the things that we have done is really worked with our community to set up strong discharge plans. Every patient who leaves our ED has a behavioral health appointment. Oftentimes we're working with the community provider to do a direct warm handoff to that provider. We will get crisis stabilization teams, ACT teams to come at the time of discharge and meet with the patient and escort them to an immediate appointment that we've arranged for them in the community upon discharge.
But the hospital system community mental health collaboration, even if they don't have that warm handoff, the expectation is they'll be seen within 5 days of leaving the hospital.
Mm-hmm.
Is that correct?
Yes, that's correct. And we've worked really hard to get a lot of walk-in clinics established so we can get an appointment almost the same day or the next day for social work services, the medication pieces within a week.
Just because it is so unusual in North Carolina with the boarding system, well, it probably happens in other places, but we have high boarding. What are the numbers that you guys deal with, kind of average patients, psychiatric patients boarding in the ED?
I'm trying to think about that. At Mission, the last couple of months have been around 35 to 37 behavioral health boarding patients, but we've really worked to reduce that number. A year or so ago, it was up 45. So we've brought it down through a lot of different initiatives. At our member hospitals, it's 1 to 2 patients a day boarding at each of the member hospitals. So in the system, that's about 6 to 7 patients boarding. We've had upwards of 72 in our Mission ED and close to 18 or 19 at our member hospitals when we were surging.
So I guess I wanted to highlight that because talking about our model, I think of it as a blended model. We're talking about using the master's level licensed behavioral health clinicians to do a lot of the patient management. So if you think of those boarding numbers, even what we've gotten it down to, if you have 30 to 40 patients a day that need a hospital bed and they're just waiting in the ED for that bed hours or days or even longer sometimes, this blended model gives a way for the psychiatric service line to manage patients over many hospital ED situations using the right scope of practice for what the patient needs at any given time. And we'll refer to that blended model again when we talk about ambulatory services.
And I'd like to add the single biggest satisfier that I hear from the rural hospitals is the disposition management that the clinicians provide, that they're actively working on getting them a bed or getting them out the door, where at the rural hospitals they have such a small staff, they're focusing on patient care, and they don't necessarily have the resources to focus on, the disposition management of that patient and, where they go, how to get them out the door, where they go next. They're focusing on the needs right now. And then, going back to what the need or what the request usually is for telepsychiatry with a psychiatrist. But we're finding some of the greatest value is in that clinician management, the intake and management of that patient.
So if you compare our blended model to the traditional telepsychiatric model, where an ED physician may get a consult from a psychiatrist, but they get some guidance, or whether the patient needs to be inpatient or outpatient, but then none of those support services. Mm-hmm. And so we're trying to manage the limited resource of psychiatrists that we have in our system and in the region, but also address a wide range of behavioral health needs.
And when you think about all that the clinician, the social worker, mental health clinician does, they're doing the crisis assessments, they're doing substance abuse assessments, they're doing the bed finding, they're really holding that involuntary commitment piece, they're getting trained on it regularly. A good portion of my staff are called first evaluators, which means they have been granted by the state to be initiators of the involuntary commitment process because they've done the training and they've have the competencies with it. They're doing daily rounding, so they're providing really a wealth of services to help the patient. Several years ago, we were not doing daily rounding and found that patients were just seeing a psychiatrist once a day, and then nobody was really tending to them. But now they're getting that daily treatment. The clinicians also speak with families. They do a lot of collateral phone calls. They'll do family sessions in the emergency department. That's things that a psychiatrist really doesn't have the bandwidth to do, and so the social workers have really worked as a team to provide that excellent patient care.
And a question we commonly get is, how do patients respond to receiving their care through telehealth? We've definitely had mixed interactions. I think overall mostly positive. And Mary might speak to that a little bit better, but they seem to respond well. They'll talk to the provider. Maybe sometimes, in some instances, they're more comfortable talking to them with that kind of distance that the telehealth equipment provides versus having them in the room.
We went into this actually a little bit skeptical. People are like, really? You're going to have psych patients talk to a screen? They're already thinking the TV's talking to them. And so there were a lot of, jokes about it. But there was skepticism, like, how's this going to work? And what I have actually found is the providers are more hesitant and have more difficulties with it than the patients. We have found that actually the patients are more comfortable talking to us. They divulge much more information on the screen than they do sometimes in person. And so that kind of turned the tables on us. We recognized that we were having issues with our comfortability, but the patients were not. I think our culture has moved to, we're used to Skype and screens and texting, and so the only time we've had some issues is if we truly have a very psychotic patient, and sometimes they may get scared or they don't understand, but generally the general populace that we serve has found it very beneficial. They have great things to say about it, and as clinicians we've found that they're actually easier to engage than sometimes face-to-face. The last thing I'll just touch on is when we do, find either a bed or we're working towards discharge, then, we're going to be in contact with the provider, the ED provider, and do everything we can to kind of shore up that, get that appointment. And then if the patient was involuntarily committed and needs to be released, we'll help the ED physician with the paperwork and just to get all those little bows tied up so that the patient is safely transported or discharged.
So we would like to talk a little bit about how we have implemented our model. And it definitely was over a period of time. We wanted to make sure that we implemented it right. So a couple of the different types of questions we get about our implementation. The technology, so what we use, it has to be as reliable as possible. We use InTouch Health as our vendor, and we actually leverage that same telehealth platform that we use for other programs such as Telestroke for telepsychiatry, for the behavioral health program. And so we have one platform that we feel is reliable. Over 95% of the time we know it's going to be on and working when we need it, which is huge when you're trying to implement something in a rural hospital that the staff time that they spend towards it, it needs to work when it's supposed to. And that is definitely one of the key successes, key drivers for success is having reliable technology in place. We staggered our implementation across our 5 member hospitals. I'll actually skip ahead a little bit and show you. So we started with our largest rural hospital at McDowell Hospital and implemented, so we were already doing some telepsychiatry there, but it was not 24/7 and it was not with the support of the behavioral health clinicians. And so we actually around the time had signed on with the NC STEP program, and but they were offering a model that was only limited hours. I think it's 8 a.m. to 6 p.m. Monday through Sunday. But what we were seeing in our system and what the need really was in our system was for 24/7 coverage. And so we implemented that first at McDowell Hospital, and then we gradually ramped it up with our remaining hospitals. And you can see the volumes going through May of this year. So we started, at McDowell Hospital, we were seeing about 30 or so patients a month. And then now today, after we have added on all of our hospitals and all of our services, we're at about 120 patients, behavioral health patients seen at our rural hospitals per month. And so going back, so this helped us, by ramping it up over time, we needed to build up the clinician staff capacity to be able to handle the volume. And so we kind of built it on at our excess capacity, I guess you could say. We did, I think we did we build up staff some, Mary?
Yes.
But it was it was minimal.
It's minimal because, I have one staff during the day that manages the 5 member hospitals and the medical floors at those hospitals. And then in the evening when they have higher volumes, I have one overnight staff, and then I have a flex person from 4 to midnight. And so that's really, but they're managing those 5 hospitals.
So staggering the ramp up helped us, build that clinician staff capacity. It helped us. When we went out to each of the hospitals, we found that each of them had different levels of readiness. So some of them did not have what we would consider safe rooms according, to the standards that we have at Mission. Some didn't have a notary available for IVCs 24/7. We had some challenges at some places with the transport services for IVC patients. And so we were presented with different challenges at every hospital that we went to. And so we worked through the standardization of the processes and the support and ramped it up over time. And so part of that too, part of the success was definitely integrating behavioral health within the process.
I will say that one of the things that we addressed was with the involuntary commitment she had touched on with notaries, but we also had to have dialogue with all the magistrates and law enforcement in each county because everyone had a different process for how they served a patient or what paperwork. Some weren't even using current paperwork. So it really took getting everyone on board and getting a solid process for who does what in each county.
Right.
And just wanted to clarify, when we say IVC, we're just shortening involuntary commitment to IVC so that people know what that abbreviation is.
Yes. So we, as much as possible, and I'll show you briefly, this is in the slide deck if you receive those. This is one of our process maps. It's essentially our standard process that we worked up for different types of scenarios, the patient when they first present to the ED, whether they need whether they present as an involuntary commit or not. So we had a standard process that we essentially took to each rural hospital, and with the ED staff there would customize it somewhat based on those available resources. We tried to standardize as much as possible, but there was definitely some room for customization per site based on the resources that were there. But then as part of the process to roll it out, we would, so we kind of co-developed that process with the ED staff, the managers, the supervisors, and the providers there, and then trained on the process and did some mock behavioral health telehealth visits. And then once we would start, we would kind of make sure we hear feedback from them, how the technology is working, how the process is working, and adjust as needed. And so I went over a little bit about our volume. So we showed over the past 3 years how we've ramped up, and we're at about 120 patients per month from our region. During that period there, we looked at some data between 2015 and 2016 where there was no change in our services or sites, and we looked at our impact on involuntary commits and length of stay. And so we found that now when we started, though, probably 100% of the boarding patients were IVC. When our 15% overturned IVC rate is over our total telebehavioral health volume. So patients that present as an IVC, those that were overturned, it was 15%. But that's over our total behavioral health volume. So we looked at the length of stay for those overturned IDCs versus the patients that were discharged IDC, and there was about a half of a day length of stay saved. And so if you apply that to the volume over that year, we saved 90 emergency department days, but likely more because that is, there are likely some patients that were not, more saved than what these numbers reflect.
And that's because, as she noted, that when we first started going in to do tele, it was almost 100% of all patients in our rural hospitals were placed under IBC if they came in seeking treatment. And so one of the biggest benefits and impacts we have, and we can kind of go to the next slide on this, is even how we impacted involuntary commitments and patient care. And so as I said earlier, when you present to an emergency department and you're seeking treatment voluntarily, you should be kept voluntary. But that it took, changing systems and processes and getting everyone on board. But what I found is the rural hospitals were very supportive of this, because in the rural hospitals, these are their neighbors. These are their family members who were being placed under involuntary commitment. So that it was very dear to their heart to keep, their uncle and their cousin voluntary if at all possible. So while we've overturned a lot of involuntary commitments and we've seen the reduced stay, there's been a lot of patients who've come in the door. It's at about 50% right now are voluntary, and so those would be a reduced stay as well.
I wanted to add just a couple of details about the rural hospitals. So most of our rural hospitals in our system are critical access hospitals, so they're very small inpatient units, 25 to 30 beds, or one of them even smaller than that. So you think about this volume, even a couple of psychiatric patients in the ED can be very disruptive to a small hospital. And then the other part of this model that we talked about is that ongoing bed finding from a central group of clinicians who are maintaining their own resource database, basically, so that they understand where the beds are in the region, other places in the state. And so that also reduces your emergency department length of stay if you have a group that's constantly staying on the bed finding rather than waiting until the next morning or another shift to do that work.
Yes, it's 24/7 bed finding, and it's relationship building. So my staff, they have strong relationships across the state with different hospitals. We have built up a strong reputation for our assessments being clinically strong, reliable. We're not going to send them a patient that surprises them. They're going to get accurate information from us, and so that reputation helps us when we refer a patient. They're going to trust the information we're giving them, and it helps them to have one person to call to. Instead of calling 6 different places, they can call one and connect with somebody 24/7 as well. So looking at some of the unintended benefits and impacts was really right off the bat with standardization. We started noticing that to really provide best patient care, we needed to standardize our policies, our procedures, our safety, our security. And so as mentioned earlier, we started going into all the rooms, and at each hospital they have a designated psych-safe room, at least one. Some of them have 3 or 4, depending on their volumes. McDowell has more rooms, Highlands has 1. But we went in and helped really to identify how best to keep the patient safe while they're in the emergency room. What's the standardization? What is Joint Commission looking at? CMS, some of the smaller hospitals. This was kind of outside of their wheelhouse, and so we came in and helped kind of lend what we knew and had learned through the years. One of the things that we helped establish was everyone at the hospitals right now is getting specific training. They've all gone through crisis prevention intervention, that's called CPI. We're also providing de-escalation to the emergency department staff, as well as trauma-informed care. And so that's just one of the things that we're rolling out across the region to make sure that everyone has the tools they need to really be able to assist our patients. We have safety sitter services. So again, we talked about that order set that goes in that kind of says this patient needs a 1-to-1 or needs arm's length. And so it kind of gives that process for how to identify who needs a sitter and where to get the sitter. We have a sitter pool that is used within Mission that if a smaller hospital needs a sitter, they can kind of tap into that pool to get somebody out there. We also have the critical incident stress management debriefings offered to our ED staff. We just had one yesterday where McDowell Hospital had a a loss of a patient. It was pretty traumatic to the staff, and so we were able to rally some team members to go and provide a CISM event for their staff. And so that's one of the things that we have noted has occurred across the region. Something that's not on my slide deck, but that we are established at Mission and are rolling out to our member hospitals is called the BERT team. It's our Behavioral Emergency Response Team. And so that's where each hospital is going to have their own team of people who are trained in trauma-informed care, de-escalation, and CPI. And it's a support team that if anyone in the hospital has a behavioral type emergency, it doesn't have to be psychiatric. Sometimes you can think of like delirium, dementia, something like that, but a team will come around that patient and come around that nursing staff to provide support to get through that incident. So that's another thing that has kind of launched with this, just in working together as a team. We're seeing that what's working in one place, let's try and do it at another place. The other thing that that was an impact was as we began to reduce the number of patients who were involuntarily committed, we ran into a transport problem, because across the state, the reason people were being 100% involuntarily committed was for the transportation issue. Because if you're involuntarily committed, then that means law enforcement has to take you and pick you up. And so people were having their rights violated for simple transportation. So we began to look at how Mission can provide secure transport when a patient is accepted to another facility. And so we have our regional transport service who provides that service. And so that's kept patients from being in the back of a law enforcement vehicle and unnecessarily, and but it provides them safety, so they're getting to a facility in a secured vehicle, but it's a safer measure, but it's just better patient care. So as we continue to expand, because that's, I guess, what I like to do is how can I grow? Another one of Mission's values is grow, 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 is our goal is to keep patients out of the emergency room. We want to get them connected to outpatient services, and what we found is we actually have quite a few of our behavioral health patients in our primary care offices. And so when there would be an urgent crisis response, or, you know, they go to their primary care doctor, and one of the first questions the primary care doctor asks is, you know, are you having thoughts to harm yourself? When they would say yes, then the primary care doctor is kind of stuck with, now what do I do? And so we began to brainstorm about how we can provide services to some of our primary care offices and expand our telehealth services to these ambulatory settings. And so while we're in the emergency departments at our member hospitals, we're also on the medical floors providing services. We're now kind of working with our primary care to help if they have a patient who presents in crisis, they can call our number and we can either beam in. We have several sites where we're providing teleservices. We have a telecart there, and we can beam in and see that patient within 15-20 minutes of getting that referral.
Yeah, so we're going to talk a little bit about some of the specific things we're doing in the ambulatory world. So I think we'll just go ahead and go to the next. Where our ambulatory telebehavioral health services have grown is that 2 years ago we began the process of trying to intentionally integrate behavioral health services into primary care. And we were doing that in a pretty traditional way, where we were hiring just a couple of licensed master's level clinicians to actually physically practice in a primary care setting. And you just can't hire an army of people to cover 18 counties. And so we had 4 in-person sites going, and then we had more requests for services in some clinics that either weren't large enough to be able to support a full-time clinical social worker or another mental health professional, or they were so far away that it would be a real difficult area to recruit and keep somebody there. And so this map shows that we have added several primary care practices that we're just offering telebehavioral health services to. In those places, like Mary had said, we're offering crisis assessments. We're also offering some brief interventions, some psychotherapy services. We're using our psychiatrists for consultation. And then we're also participating in some care coordination. Our primary care network has also been piloting team-based care processes. And so one of our rural ones at the top, the northern part of that map there, in Mitchell County, we have a mental health clinician that is weekly doing case consults with the on-site clinical pharmacist and the RN care manager and anybody else from the team that can join. And they are just weekly going through some of their most complex cases to have that team-based approach. So if we jump to the next slide. So the same model that we talked about a few slides ago of a blended model of telebehavioral health, where we're using master's level clinicians as much as we can in the right scope of practice with psychiatry support. So if you think about a primary care provider's needs in a rural community, they're used to just taking care of everything, including psychiatric conditions. And when you ask them what they want, they will typically say that they want to have a psychiatrist that they can talk to directly or that their patients can talk to directly. And what we've realized is there is no health system that has enough psychiatrists to dedicate time for every clinic every week with a psychiatrist. So we're using this blended model of having master's level clinicians available to do immediate triage kinds of services with the practice, and then also to be able to go from that, if it's an acute need, they can triage, they can make a plan, they can help the primary care provider with a disposition. If it is not something that is so acute that the patient needs to be moved on to a higher level of service, they can provide a brief series of counseling visits through tele for those patients. So we have our psychiatrists that are providing support to the clinicians that are doing telehealth. We recognize some gaps in crisis, between crisis and outpatient care. So we're using a primary care behavioral health model, and that is a model that's been written about and studied. It's really a primary care version of community mental health. So you're used to your primary care providers being generalists and doing a lot of specialty care as far as they can go with that. And so your primary care provider will deal with headaches, they'll deal with some diabetes, some heart issues, and then if they need to have a specialist, they'll make that referral. Our integrated behavioral health clinicians are doing the same thing. They are providing brief interventions in these clinics, brief as in the frequency of visits. We could do just a one-off consult visit, or we would do up to 4 or 5 follow-up visits. Typically, these primary care visits are 20 minutes in length, and they're really focused on patient functioning rather than in-depth diagnosing and psychopathology. We're connecting with the patients and helping them get back to a higher level of functioning in their life. If you think of rural community behavioral health needs, typically there's a shortage of behavioral health clinicians and specialists in the community. There may be stigma attached to going to the only mental health center in that town, and everybody knows you and everybody recognizes your car sitting in that parking lot. So we have found that primary care patients are very willing to come back to their doctor's office where they feel comfortable, they feel like they're known. If we use terms like how to help you manage with stress, then they don't feel like they're being told that they have more disorders or more diagnoses, and they're more willing to work on being more active in their own care. The consultative psychiatric piece, I think, has been something that I have really enjoyed being a part of, is that our psychiatrists, we have a pediatric psychiatrist and adult psychiatrist that are involved in our ambulatory care, and their goal really is to come along the primary care providers and support them in caring for their own patients with behavioral health needs. And so when our psychiatrist does even a direct patient consult through Tele, they're not taking over care, they're collaborating with the primary care provider. So they will provide the primary care provider with specific recommendations for understanding diagnoses, for medication suggestions, labs that they might need to be following the patient with. The psychiatrist is available to consult directly with the primary care provider, either through chart reviews in the EHR or by phone or secure messaging. They also have provided lunch and learns and WebEx sessions to primary care, all with the goal of helping expand the primary care capacity to manage behavioral health in their own clinic. The example I love to give is in the summer of 2015, we started having a pediatric psychiatrist beaming into one of our primary care practices, a pediatric clinic in McDowell County. And so she has been doing one afternoon a week. So she's doing a couple of consults, some follow-up visits directly with patients, children and their family. But since, now we're coming up on 2 years, this pediatric psychiatrist has not made any orders in the chart, has not prescribed any medications. All of the patient orders and the care has come from their primary care provider with a lot of support from the psychiatrist. They can message again through the EHR. She gives them her cell phone number. They can contact her anytime they have questions. And we've seen one of the nurse practitioners in that clinic really step up to be the person that follows some of the challenging behavioral health cases. And they had a really challenging teenage girl who was bouncing around the foster care system, and she was only going to be in their county for a brief period of time. And that practice, with the help of the psychiatrist, was willing to start this young lady on lithium and manage her mood-stabilizing medication for a couple of months while she was in their care. And that's something that a year previously the primary care practice would have never jumped into. So where we're branching off now from kind of those straightforward integrated behavioral health care and primary care is to offer some specialty care. Everybody on the call knows that many communities in the country are facing an opioid epidemic, and the challenge for primary care providers is the appropriate prescribing and managing of folks that may need other medications like Suboxone or buprenorphine. In North Carolina, our Medicaid system has just this year released a clinical coverage policy for office-based opioid treatment, which has really high standards for behavioral health and substance abuse workup for the patients on that medication. So Mary's group of clinicians are now available to beam into a primary care practice to provide that initial workup, help with some specialized brief interventions, and then referral to other community services if necessary. So that's quickly how we used our same blended model that we were talking about in emergency departments and inpatient in the ambulatory world. So the implementation challenges for ambulatory, even though Mary and Amy had worked through a lot of kinks in the inpatient world, we came to appreciate that even though our inpatient and our ambulatory systems use the same Cerner platform, there's a lot of division between inpatient and outpatient as far as the informatics, the forms and the process, the registration issues with patients, the billing issues. So we have had a lot of things we've had to learn to make it so that the same clinician could do inpatient consults through tele and ambulatory consults. One of the things that's been very helpful is we made a conscious decision to use the same telehealth technology platform for both, so that our central location, they don't have to be switching from one form of transmission or software to another. They're using the same thing. That's the best way to say that, Amy?
Yeah.
So we also learned along the way that it does not, you're not going to be successful just dropping a piece of equipment in a primary care practice. So Amy has done a great job of finding us very nimble telehealth carts, basically a computer on wheels, so that the telehealth behavioral integration can be just like you would do in person. You roll the cart right into the exam room where the patient is being seen. You can connect very quickly, but we weren't getting a lot of utilization of that until we started engaging the practices to help them understand what the service could do for them. We had one practice where we didn't know that we were having connectivity issues in that practice, and so we had to get our IT folks to work through that. So much more testing on the front end allows us to not disappoint them with technology challenges. And we are now moving toward, when we bring up a new ambulatory site, we're actually going to send one of our telehealth clinicians out there to embed them in that clinic for a brief period of time so that they can develop relationships with the primary care providers and their staff, because the nursing staff and support staff are really key in making sure that this works smoothly. And then they can do some of that work in person and have those follow-up conversations with the providers so they can understand what they can get out of the telehealth services. And then we realized from our first couple of pilots that rarely are they satisfied just having a crisis evaluation. Because they're in a rural county, they're then saying, so now what am I supposed to do with my patient? You know, they're going to go on somebody's waiting list, or they've already been to the other mental health provider in town and they don't want to go back. And so we are now offering more than just acute services. We're offering, like I said earlier, those brief series of follow-up counseling visits that can be done in the primary care practice. So reliability, engagement to develop the relationships, help them understand what they can get, and then trying to be responsive to primary care providers wanting help with their opiate care, wanting help with patients that could use just some brief interventions. So that's what we've learned in the process. We were trying to save about 5 minutes at the end for questions, and that's where we are right now. So I wanted to give people on the line an opportunity to shoot a question through the application, or they could unmute their phone and ask if they would like.
Yes, and *2 to unmute your phone line, or feel free to use the chat box to submit a question. Well, I thought this was an excellent webinar, and I want to thank you all for being on here and speaking today. It looks like Sheila has a question that, looks like Sheila has a question, and she's typing it into the chat box, so we'll give her just a minute here. While we're waiting, I just want to remind you to please complete the short online assessment by clicking on the link on the screen. You can check out any of our upcoming health webinars and PMG calls, or check out our health webinar playback. All right. Sheila says, did you contact all payers prior to setting up before you went forward with the telehealth service?
We contacted most payers, and I would say where we spent the most of our work is with our Medicaid managed care organization for our part of the state. North Carolina has several local management entities that operate as MCOs for Medicaid behavioral health, so it's a carve-out right now still for behavioral health. And we did a lot of work to make sure that they understood what we were providing. They were very encouraging and really were wanting to help make this successful because they are supporting the integration of behavioral health into primary care. The other thing we did with other payers is really make sure we understand what clinicians they credential to do telehealth services. That's been a challenge for the workforce. So most folks are familiar with the fact that CMS, Medicare, only directly enrolls licensed clinical social workers and PhD psychologists to do Medicare direct behavioral health services, and that includes telehealth. Several of the commercial payers have chosen to follow that Medicare limitation. So we have had to be very selective with our master's level clinicians being licensed clinical social workers for our telehealth services. The other thing we had to have a good understanding of is what part of our region is a metropolitan statistical area. And so that an MSA, metropolitan statistical area, is not eligible to receive telehealth. You can broadcast from there, but not to there. Fortunately for us, the majority of our system outside of Asheville qualifies as rural and is eligible. But those two things, the licensure of, or the credentialing clinicians and the geographical ability to receive telehealth, were the two limiting factors.
Great.
Good question. Thank you.
All right. Any other questions before we close for the day? Well, if you come up with any more questions or comments, you can contact me at the email link on the screen. We hope to have you all on future calls. Thank you again to Mission Health for being here today.
You're welcome. Thank you.
Thank you.
Thank you.
Have a great afternoon, everyone.